Our topic is prostate cancer. There's a lot of controversies that surround prostate cancer, and we're going to try to tackle most of them. Prostate cancer, our incidence is 20% and 11% of the deaths. This year, there'll be 230,000 new diagnosis. As the baby boomers come into this age group, we expect a tremendous increase in that incidence, close to 500,000 cases. And most of the treatment for prostate cancer that we have experienced up until, I would say, the last year or two possibly, have been fairly aggressive treatment strategies that involve the totality of the prostate. There are other alternatives. Now, PSA has been around for about 20 years. But what we've learned about PSA is that it's prostate-specific, but not prostate cancer-specific. A prostate screening, and we threw that net over a group of those men and brought them in and tested them, that would be true screening. As we all know, that probably isn't what happens. We're talking about PSA as a screening tool. Let's talk first about PSA as an oncologic marker. What it can do for us when we want to know if there's cancer present. It's the gold standard as of today. PSA as a screening tool is what is under the gun. Now, let's talk about it as a marker for screening. Here's where the controversy comes in. The United States Preventative Task Force, they are physicians, and for the most part, they're family practice physicians. There's not a specialty expert on their panel. And they've come up with a recommendation that PSA screening should be abandoned. Dr. Fabra is the chairman of the panel, and I'm sure his command of statistics would outstrip anybody that I know. He is not a urologist, nor is there anybody on the panel that has the expertise. And yet, the recommendation may very well influence how the IPAD looks at PSA when it comes to screening. This program is up on our website, and it deals with the randomized screening study done using PSA in Europe, United States, and Goldberg. This group of studies is the basis upon which the U.S. Preventative Task Force made the recommendations. They didn't do one iota of basic research. All they did was analyze from a statistical basis the information that was provided by these three studies. And should that then, because of this group, which is not a government, but an independent group, influence your health care? I reviewed what they did. I reviewed how they criticized PSA and its application. And you know, I can only come away with saying their interpretation was a total misinterpretation. They don't question the value of PSA, although they say don't use it. What they say is, you'll find the diagnosis of prostate cancer and you'll treat it. Complications of treatment are to the point that they neutralize the value of knowing that a person has prostate cancer. My interpretation of that is, let's look at the treatment. Their conclusion was that they gave it a D. D is discourage the use of this service. But here's the PSA era. Mortality, death from prostate cancer. And look what's happening to it. We had the privilege of living through this era and how limited we were in being able to provide meaningful treatment for that group of patients. Let's move to new markers, just so you know there's progress in this area. PCA3. Sounds similar to PSA, but it is quite different. PCA3 is a non-coding RNA. It is overexpressed in urine, so it's not hard to find. a vigorous rectal massage, and then take that urine and have it analyzed. And this was just recently approved by the FDA. If you do a PCA3, if the quotient is less than 20, you have a pretty good idea that there's not much going on in this prostate. If you have a level quotient that is above 50, you have a pretty good idea that there's trouble brewing or how severe it might be. And I want to talk about the 3T MRI. Current MRIs are half that strength. The 3-Tesla MRI has a much better picture. It has more of those adjustments. It allows you to look for trouble in what it's focused on. Diffusion contrast enhanced imaging. Diffusion weighted imaging simply means how water is shifted around in cells. There is the spectrographic capability where you can actually look for chemical composition within the cells. In this particular case, there's clearly something going on here. You might say it lights up like a Christmas tree. And if you know the color of the trouble you're looking for, it's not too hard to think you might find it. Here's a 3T MRI. Here's an area that looks different from the rest of the prostate. It's called a map. And we map the prostate. We talked about insignificant cancer. There's also significant cancer. We then looked with a good camera. We took a needle and put it into there, and you found, quote, an insignificant cancer here, but a very high-grade, aggressive cancer there. If you have a treatment that you could focus on this area and not necessarily treat this area, the larger lesion represents what we call the index lesion. The index lesion is a cancer that is significant. The chemistry of the index lesion is uniformly found in the metastatic disease. The lesser lesions, you don't have that. We replaced the biopsy with an MRI of the Q3 variety. We could see the big lesions. We know what they are, and we treated them. We wouldn't be talking about taking out prostates. They wouldn't be stressed as they are in a major operative procedure, active surveillance. That means watching carefully. We biopsy that patient. That is a low Gleason score. And there isn't a big volume of tumor. So let's just say there's small deposits of not aggressive cancer in the prostate. That would fit the definition of insignificant cancer. That patient could very well, and probably will do very well, if you put them in a surveillance program. And after a surveillance program can make a lot of sense. And if you see the markers change, then you act. Cryosurgery. We've been doing cryosurgery for a very long time. 1990s, a new generation of cryoablative treatment tools came about. This is basically what we do. We use ultrasound. It's a lot like that mapping biopsy. We know where the prostate is. Our goal is to treat the entire prostate. I presented this paper in Russia at Duke University and at the American Urological Association North Central Section. And at that section meeting, we got the award for the best poster presentation. What do I want to show you here? First, we had 82 patients. We followed them for over 5 years, and we had an 86% cure rate based on every way we could measure it through that 5-year period.